Our next topic for presentation is by Dr. Kemal Ozgur of Turkey. He will be speaking on OHSS prevention with GnRH agonist trigger. Dr. Kemal Ozgur completed his residency in obstetrics and gynecology in '93 at the Agonist University in Turkey, after which he completed a 3-year fellowship in reproductive endocrinology and infertility at Tygerberg Hospital, South Africa, and Norfolk in the USA. He returned to his university in '97 and established the IVF unit there. He then founded the Antalya IVF, which is the largest IVF center in southern Turkey. His major areas of interest are assisted reproduction, andrology. He has published extensively in these fields with over 30 articles in renowned international journals. Dr. Kemal Ozgur.
My topic is the prevention of OHSS with GnRH agonist trigger. Now, the OHSS may sometimes be very critical, even it may be mortal for the patient, and the death rate has been found that every 50,000 cycles there is one death. And it's not just that, sometimes it may be this, with severe OHSS we see very severe conditions like thromboembolic events which may jeopardize of the patient's health for the future. Now we know that there is 2 stages. One is early stage and the other one is late stage. Early stage is the one which happens with our HCG that we give the patient, and the late one comes from the embryo. And usually the late one is much more severe, and it's unpredictable for the duration of the OHSS is unpredictable. I remember one patient which we followed her until 26 weeks of pregnancy, and we did almost every other day puncture of choledocentesis to retrieve fluid from her abdomen. So sometimes it can be very disturbing. Now, what's the mechanism of OHSS? It's mainly the VEGF is the responsible molecule which makes OHSS, and it has been found that HCG upregulates the VEGF secretion. And how it affects VEGF? Through its receptors, the loss of the fluid to the third space happens, and it's this loss is the making the OHSS clinic. Now we are talking about HCG. HCG is actually it's a very old hormone. It's the first it's first invented hormone in 1927, and then afterwards the other hormones has been invented. But until 91. HCG was the only trigger tool, and in 91, Itzkoitz from Israel, he was the first using agonist for triggering the ovulation. And in these days, there was no antagonist, but after 2000, then agonist was used with antagonists. This is the picture of LH and HCG. The shapes of the molecular shape, but the main difference is coming from the oligosaccharides, and these oligosaccharides of the HCG makes the triggering of the luteal triggering of ovulation, as well as the luteal phase support is done by HCG. So it binds like 7 to 10 days of the LH receptors. The GnRH agonist trigger and natural trigger, if we compare them, the GnRH agonist trigger is shorter. If we compare to like around 14 hours of half-life with GnRH agonist, you see it's natural. It's LH trigger, but in natural life it's much more longer. It's like double times of the longer. What's different between HCG and agonist? First thing is it has a longer half-life, the HCG, because of oligosaccharides, 7 to 10 days, and versus agonist is just 14 hours. And there is very prolonged and higher estrogen and progesterone in HCG. I will show you in some data that very high estrogen progesterone with HCG compared to very low estrogen progesterone with GnRH agonists. And the LH is just reverse. You see very low LH because of the high level of estrogen progesterone. You know that it suppressed LH. And in agonist, you see higher LH, which is close to the normal and natural cycle. And we see increased OHSS with HCG-triggered cycles, and we see no OHSS with GnRH agonist trigger if you don't give HCG as a support. And both LH and FSH, and the other most important thing is, you know that from the basics that in natural life, in natural cycle, the LH increase, it triggers the ovulation, but you also see there is an increase in FSH. But in HCG cycle, you don't see any effect of FSH. So it's just LH type of effect. So because of this FSH rise, you might see something positive, which I will mention in my next slides. Now, control, if you compare the control ovarian stimulation with natural cycle, it's not physiologic. It's something supraphysiologic, because first thing you have one follicle and then you have many follicles, multiple follicles. And because of this, there's a high levels of estrogen and high level of estrogens. And the other important thing is you have to trigger the cycle, otherwise you cannot retrieve the eggs. So you have to trigger, the triggering mechanism is HCG. It's not a normal hormone, it's not like natural one. It just mimics the effect, but it has some side effects I will mention again. That's why, because of this supraphysiology, we see that the endometrium is not same. The endometrial, there are many studies that there is an advanced histological advancement in endometrium. And also the inhibition of LH secretion with HCG when you trigger, it's very profound. It's very low levels because of high estrogen and progesterone. Now our aim is, of course, OHSS-free clinics, and there is no doubt that in the studies with GnRH agonists, purely GnRH agonist triggers, there's no OHSS. And this study was a meta-analysis from Hugues. He has compared agonist cycle, randomized, just compared randomized control cycles. And among 2005 agonist cycles, agonist trigger cycles, there was not a single case of OHSS compared to HCG trigger cycles, which was 1800, and there was like 5.1% of OHSA. So there is no doubt that if you give just GnRH agonist trigger, there is no, it's completely OHSS risk is gone. But the most important thing is, when you look at the outcome of these patients, the outcome is very low. That's why in 2011, the Cochrane review by Yusuf and his colleagues, he found that the odds ratio for live birth rate was 0.44, which was very low. And he recommended that GnRH agonists should not be used routinely for fresh cycles because of low ongoing pregnancy and live birth rates. And his meta-analysis was done with normal luteal phase support, which was before like 2006. The data was mainly coming from these early learning curve of GnRH agonists. This is one of the studies that was in the meta-analysis. It was from Hugues at 2005, and he randomized the patients with agonist trigger and HCG. And you see there's a profound decrease in the outcome. This is the graph of his results. You can see that the pregnancy rate, especially the clinic pregnancies, was very low, 6.3, and there is very high loss of pregnancy, and also the implantation rate was also very low, you can see. Why was that? The reason was when you look at the endocrine parameters of this study, he checked the estrogen and progesterone at luteal phase. And this is the table, but this is the graph. And you can see that this is the estrogen and this is the progesterone. You see that and the purple one is ACG and the other one is agonist, buserelin. You see that estrogen and progesterone is very high, and compared to buserelin, it's very low in luteal phase. And when you look at LH and FSH, it's just the reverse. The LH and FSH is high in GnRH agonist and low in ACG. So what we need more estradiol and progesterone. That's why that's why his patient was losing pregnancy and did not implant because of low estrogen and progesterone. So what Humaiden and his colleague has done, he rescued the luteal phase by injecting 1500 of ACG. This is the first randomized study published in 2010 by Humaiden. Actually, it is something paradoxical because you are avoiding the bad guy, and that's why you give ACG agonist, but then you are calling back the bad guy again. Come and help me. But the difference is 1500 is just almost like one fourth of there's two main points. One is the dose of ACG is very low. It's like 1/4 of normal regular dose, and the other thing is that time. The time of ACG you are giving is not as a triggering purpose at the time of triggering. You give it after 36 hours after the pickup. So, during the pickup. So the time and the dose is different than the normal ACG triggering cycles. And what he found was that the ongoing pregnancy rates, then suddenly it was the lowness of the ongoing pregnancy just disappeared, and it became equal with when you rescue the luteal phase with 1500 of ACG. And there is one study from Australian group, and it was published in 2001. 71 women with high risk of OHSS. They were triggered with GnRH agonist plus 1500 of ACG for luteal phase support, and they had excellent result. They had, with one single embryo transfer, they had like a clinical pregnancy rate of 52.1, and miscarriage was around like 5%. They just had one severe OHSS out of these 71 patients. So the OHSS doesn't disappear. It's still there, but the severeness of the OHSS and the frequency and the incidence is maybe getting lower. So how is the endocrine? There is the last month, just recently, there was a publication from Belgium group. They measured the endocrine profiles of these patients and they compared them. And you see the graphs. This is the progesterone and this is the estrogen of these four groups. You see this is ACG. The red one is just ACG trigger, regular cycles, and then agonist plus ACG, modified ACG with luteal phase support, and agonist without any ACG and agonist without any support. And you can see that progesterone levels, the red one and the green one was higher than the blue and red one, which was there was no ACG. So you can see clearly the evidence of the progesterone and estrogen rise in ACG cycles. And when you look at the LH and FSH, you can see that the green one and the red ones are differs. Like you would see that the ACG, the LH and FSH is profoundly decreased. But when you give agonist plus ACG, LH and FSH do not decrease. So it's very close to the natural cycle. The LH and FSH levels are good compared to just ACG. So if we come to our data, we analyzed our data. We have been using like 3 years of GnRH agonist triggers, and we have I believe we have a good experience with GnRH agonist. We gathered our 2 years of data. This is the description of our treatment cycle. We give antagonist, and we start antagonist at when the patient has 12 millimeter, more than 12 millimeter of follicles. And then the ovulation was triggered either with ACG or with GnRH agonist with triptorelin acetate 2 ampoules, which is 0.2 milligram of triptorelin acetate. We denude the oocytes immediately after pickup. That's our practice. We don't wait for denudation. That's why we can see more. The maturation can be seen more in our treatment, and then we pre-incubate oocytes for 3 hours before doing ICSI. And maximum 2 embryos has been replaced on day 3 or day 5. This is the graph of how we have done our treatment cycle. We give this is the FSH and HMG sometimes, and this is the trigger type. And when we have a agonist trigger, we always give ACG 1/4 at day of pickup. I just want to also add that we measure LH and progesterone after when we give GnRH agonist trigger the next day before pickup, so that we want to make sure that the agonist has worked and there is LH and FSH trigger at the same time. And otherwise, the luteal phase support is the same. We give estradiol of 2 milligram and progesterone as usual to our patient until the pregnancy, and then we continue on. We had like a agonist trigger 152 cases, and we have ACG trigger of 398 patients. These are all patients who has more than 14 oocytes, or we have included the analyze more than 14 oocytes. And we measure the embryo quality, we measure the maturation index of the oocytes, and the fertilization index, and pregnancy outcome, and the embryology quality has been done by top quality day 3 embryos and day 5 embryos. So if we look at our results, this is our results table. We have a 214 cycles of ACG and 104 agonist cycles. When we look at the results section, we can see that the pregnancy, the age was different. The age of these agonist cycles, patients were much more younger, because maybe they have, in younger age, you have high response. And the number of the oocytes are also higher, maybe because of the younger age, or maybe because of the FSH and LH trigger. And when we checked the pregnancy rate was not significant. The ongoing pregnancy rate for the ACG was 43.9 and 50% for the agonist trigger group. So it wasn't statistically significant, the outcome, the pregnancy rates, and you can see from the graph. And when we make the equal number of oocytes, when we select the high response equal number of follicles, the oocyte numbers were, this is 33, on average 33, and this is very striking. The maturation index was very high statistically significant high in agonist group, 62 versus 73. The other top quality embryos, blastocyst, it wasn't different, but the maturation index was high. And we believe that it's coming from agonist, and maybe it's because of the FSH trigger with agonist trigger, which increase the egg quality. And we can see that a little bit higher fertilization rate, but these parameters are not statistically significant. Now, when we check our frozen embryos from those cycles, it was interesting. we found that with agonist trigger and we compare agonist trigger and HCG trigger, and the pregnancy rate per cycle was 65% of HCG versus 87.9, which was surprising for us, and this was statistically significant. Just for one cycle of towing cycle of agonist cycle was 87.9, which is very high. This is again the graph of this. So there must be something, maybe for the luteal phase support may not be very good, but we know that from this slide, from our results, that the embryo quality is very much affected by the oocyte coming from agonist trigger. How about OHSS? Did it make any difference with agonist plus HCG? We had a similar OHSS. It didn't prevent OHSS. The rate was 8.2 versus 6.6. However, there was something different. The distribution of the early and late. We see more late OHSS in HCG compared to agonist cycle, because in agonist we have like 21% of our OHSS was late. Compared to 50% of OHSS was late in HCG. So this is also interesting. And also what we have seen, I mean, in my experience, we see maybe we don't see less OHSS, but it's much more milder. I know that after we have introduced GnRH agonist trigger in our center, it's a busy clinic, and we have seen that the paracentesis that we have done is very rare now. I mean, I remember every other day we were doing paracentesis, and the patient was admitted to our center all the time. But now it's very rare now. Therefore, I firmly in my practice believe that it's very effective. And this slide also showed the OHSS, which is more than 15 oocytes. The late this one, as I told you, that the late proportion was high in agonist trigger. And this slide also, when we decide, we'll retrieve the eggs, and then we decide later from the clinic that we have to freeze the embryos, all the embryos, freeze all cycles with agonist plus HCG and ACG. When we look at these cycles, the agonist plus HCG, we see only 13.5 of OHSS compared to ACG cycle. We see almost double than this percentage. This slide shows that the HCG effect, triggering HCG, is much more severe than the agonist trigger. So in conclusion, OHSS risk is none with freeze all embryos and less and mild with modified luteal phase support. And we see definitely greater in vivo oocyte maturation, as I showed you in my data, significantly more metaphase 2 oocytes, and maybe good embryos. It may have, in the future, it may be shown that the fertilization and the embryologic quality may be better, although in our study it wasn't statistically significant. It may have better pregnancy outcomes. Definitely we have shown that in our frozen cycles with agonist trigger, we have much higher pregnancy rates. And if you are using GnRH agonist trigger, you shouldn't use without modified luteal phase support. I mean, if you don't use HCG, then of course it will not work, and your patient will not get pregnant, and you will lose the pregnancy as well, because the rates are very low. And I am sure in the future there will be some dose finding studies. Maybe below 1500 may be enough for let's say 500,000 of ACG may be enough for luteal phase support. So the rate of OHSS with luteal phase support with modified type 1, modified type may decrease. And in the future, I'm sure there could be something with this luteal phase support without ACG also maybe another option to eliminate OHSS. Thank you for your patience.
Any questions from the floor? I have a question, doctor. Do you supplement progesterone also in the luteal phase or only HCG 1500?
Oh yeah, we give crinone gel
also.
Yeah, also, yes.
Yeah. What is your opinion regarding the multiple dose of agonist instead of single dose triggering?
Trigger multiple dose?
Yeah. Because its half-life is only very short when compared to the HCG. Some people give multiple doses, twice.
Twice at the same time or different times?
No, for agonist triggering, yes. You are giving dose.
Just single dose, yes.
Single dose. So do you recommend second dose after 12 hours?
No, I do not recommend because we measure the LH and progesterone the next day. If the LH and progesterone did not rise, then it's logical to give one dose again. But if it rises, then there's no need.
Okay. Thank you very much, Doctor.
Thank you.